fusion, coagulopathy, and also the environmental loss, that is hypothermia. So again, these three things are interlinked: hypoperfusion, coagulopathy. So one is leading to another. So we should remember all these things in trauma, particularly in case of severe trauma. Now let's come to the today's topic. This first topic is optimal blood pressure. So what's the blood pressure we need to keep? Do we keep the patients normotensive? Do we keep the patients hypotensive? What is the recent evidence on this particular topic? One thing is for sure that even if we are talking about hypotensive resuscitation, we are talking about resuscitation before surgical hemorrhage control and resuscitation after surgical hemorrhage control, even if we are talking about hypotensive. The ATLS way, the fluid management, is a standard management where we are giving a bolus of 2000 ml of ringal lactate or normal saline bolus and 20 ml per kg in children. So fluid management is a cornerstone of ATLS. But if hypotension persists in ATLS, we talk about immediate blood transfusion. That's the ATLS protocol. So what's this permissive hypotension? All of us have heard about it, read about it somewhere. What's the exact thing? The proponents of permissive hypotension say that if you keep the patient hypotensive, then you don't raise the blood pressure and you don't pop the clot. You favor coagulation. Suppose if there's an intraabdominal bleed and you raise the blood pressure to normotensive, then there will be further bleeding because of the hypertension. Hypotension can be tolerated until surgical control can be achieved. Standard fluid resuscitation, people say, no. Organ ischemia is bad and optimized organ perfusion is necessary. Now this, one of the landmark studies that came up in 1994, as you can see there, the New England Journal of Medicine by Bickwell, W.H. and et al. About hypotensive resuscitation. It's a very nice study. How do they achieve that? The hypotensive camp says that if the patient is normotensive, then don't administer any fluids. If hypotensive, administer controlled IV fluids, 25 to 500 ml boluses until the goal of radial pulse is achieved or appropriate maintenance in non-head injury patient is achieved, or the MAP of 40 to 60, or systolic blood pressure. The systolic blood pressure, they are talking between 80 to 90. But what are the issues where we can't do hypotensive resuscitation in cases where we have cerebral head injury because of problems with the cerebral perfusion and causing rise to secondary brain injury? And none of these studies in the literature have gone beyond 120 minutes. So we don't know, none of them have gone beyond 1. So how long can we continue this hypotensive? And of course, there are a lot of studies which say that if you have protracted hypotension, many of the patients in India, they reach late to the hospital. If they have protracted hypotension, then it can reach to tissue hypoperfusion and acidosis. And the lower limits, how low can you go? Can you go down to 70? Can you go down to 60? That is also not been studied properly. Another concept we need to know is the damage control surgery and damage control resuscitation. This is a concept which has come from the Iraq war, where you have got bad severely abdominal injuries. You open up the abdomen, you pack the abdomen, come out, do the resuscitation, go back into the abdomen, and again resuscitate. So you do parallel things. You do the damage control surgery as well as damage control hypotension, damage control resuscitation simultaneously. So like previously we used to have resuscitation, damage control surgery. Now we have simultaneously both the things going on. So what are the goals? Goals before hemorrhage control, as you can see, systolic blood pressure of 80 and rest of the things are self-explanatory. After hemorrhage control, mean blood pressure of more than 90 and of course the urine output and normalized hematocrit, normalized coagulation and other things. So these are the goals we need to achieve. Now let's go, so this is about the blood pressure. So what's the optimal blood pressure? Do we have exact blood pressure? No, the exact answer is not yet known, but there are different trials going on. Now let's go to the next topic, the coagulation. In coagulation, two things which we need to understand is something called as trauma-induced coagulopathy and acute trauma coagulopathy. These are not synonymous, these are slightly different terms. Let's try to understand what they are. This is a normal coagulation cascade. All of us know that. The initiation, amplification, propagation, and all those things. The trauma-induced coagulopathy, as we have seen, is predominantly caused by severe bleeding, then giving rise to fluid management, giving rise to massive transfusion, hypothermia, dilution of coagulation factors, tissue hypoxia, acidosis, and coagulopathy. That is also consumption of coagulation factors. But whereas the acute trauma coagulopathy is a concept where they have seen that the patients arrive in a coagulopathy state on arrival, and that is because due to tissue hypoperfusion and not as normally believed as consumption of coagulation factors. They say that it is activation of anticoagulant protein C pathway and not consumption of coagulation factors that causes the acute trauma coagulopathy. And remember that these patients have got higher chance of dying, 4 times higher chance of dying than the patients with normal coagulation on arrival. That's how they explain the acute trauma coagulopathy. So these are the two terms which we need to know, the trauma-induced coagulopathy and acute trauma coagulopathy. Now, how would you define massive hemorrhage? Well, some say that, okay, if the patient's whole volume is replaced in 24 hours, that's massive hemorrhage, though, or massive hemorrhage transfusion protocols should be in place, or if more than 10 RBCs are given in 24 hours, or blood loss of more than 150 ml. So these are the different definitions, because they want to have a standard definition of coagulopathy, they want to have a standard definition of massive hemorrhage. So these are the different definitions that have been given in various trials, or replacement of 50% of the blood volume in 3 hours, because we can't wait for 24 hours till we say that now it's massive hemorrhage. And then again the definition of coagulopathy. There are various variables which are taken. One is the prothrombin time and APTT more than 1.5 times the normal, and INR more than 1.5 times. INR more than 1.5. So these are the different definitions of coagulopathy that have been given. So let's look at the coagulation targets. What are the targets we want to achieve in these trauma patients? The hemoglobin needs to be maintained at 7 to 9. Prothrombin time should be APTT and INR should be tried to be normalized. Platelets should be kept more than 50,000, but more than 100,000 for severely and continuously profusely bleeding patients. Fibrinogen level should be more than 1.2 to 2, and ionic calcium. So these are now, as you can see there, the European guidelines have come up. The management of bleeding following major trauma and updated European guidelines have come up in 2010, and they have exhaustively dealt with the whole literature that's available in trauma. They have dealt with oxygenation, they have dealt with coagulation, they have dealt with everything. Everything has been dealt in detail. It's a very big 29-page document, I think. Massive hemorrhage protocols. Well, what do we give to control hemorrhage? Of course, we give RBCs, we give FFPs, we give platelets, cryoprecipitate, and fibrinogen concentrate. Of course, the FFPs and cryo actually basically contain the same thing, but the cryoprecipitate, the volume is much lesser, and it is rich in different factors like 8, 13, and Wolff-Raynaud factors. What are the ratios? How much platelets? How much RBCs you want to give? FFPs to RBC ratio. Normally they say 1 is to 1.4, but now it is recommended, particularly after the Iraq war experience, they are saying you give 1 is to 1, particularly in massive trauma where you are talking about massive hemorrhage. So these are the various doses that can be given. FFPs 10 to 15 ml for control of ml per kg. Cryoprecipitate can be given at 50 milligrams per kg or 15 to 20 units of cryo. And fibrinogen is also available. It can be given to, as 3 to 4 grams initial dose. Now, after discussing all these FFPs, platelets, and all these things, cryo, do we use factor 7A? Well, it has been again used in the Iraq war, but again, it should be used only as a last resort where you have tried everything to control hemorrhage, you have tried to stop the coagulopathy, you have tried to replace the blood products, and then you are thinking about factor 7A. And of course, the antifibrinolytic, where there is increased chances of fibrinolysis. Now again, in the European guidelines, they have classified these recommendations as 1A, 1B, 1C, 2A, 2C. So the factor 7A and the factor, the antifibrinolytic treatment is, I think, 2A or 2B, I think. So it's much lower down the line. So to conclude this, management of critical bleeding patients with coagulopathy, one has to remember that one has to treat the problem first. So treat the hypothermia, which will cause further coagulopathy, acidosis, correct the coagulopathy, and then do the lab test, and you have to then give the FFPs, RBCs, and then you can think about the factor 8, factor 7A. The new technology in coagulation, I will not dwell into it much, but just to remember a few names: thromboelastography and thromboelastometry. These are two new things which are coming up. Now regarding the oxygenation, that's the last optimization topic. We all know that decreased hypoperfusion, decreased oxygenation will cause oxygen depth, anaerobic glycolysis, increased lactate and acidosis. All of us have heard Dr. Singer and so many other people talking about how do you optimize oxygenation at the tissue level. So what are the oxygenation targets? Of course, the standard things first. The clinical targets, the blood pressure, the heart rate, the respiratory rate, the capillary refill time, the urine output. So these are the standard things, of course, which will help in the oxygenation of the tissues. And then what are the surrogate markers? As it has been elaborately explained in today's morning session, we try to keep the pH normal, the lactates of less than 1.5. Dr. Vincent was talking about lactates less than 1. arterial base deficit or excess less than 3 milliequivalents per liter. SCVO2 again, we know that the reverse trial where we try to maintain the SCVO2 more than 70%, and the NIRS. The NIRS is available. I think it's here also. I have seen it yesterday in one of the stalls. So it can be used. How does NIRS work? It is a light wave of 700 to 1000 nanometers to the skin, bone, and muscle. Different absorption spectra for oxyhemoglobin and deoxyhemoglobin, and degree of tissue oxidation can be seen. That's what they say. And they have got certain normal values. I think they are talking about 60 to 80 or 80 to 90 for tissue oxidation. So that's how you can measure the tissue oxidation. So again, coming back to the oxidation, you first normalize the patient, the normal rate, the urine output, stabilize the patient. If the arterial blood lactates are normalizing and the arterial pH is normalizing, then the patient is probably resuscitated. But if it continues to have worsening of the lactates, worsening of the pH, then there could be probably occult hypoperfusion. So that we need to identify. Now, why are we so worried about the lactates? The absolute values of lactates are not important, but it is more important that when you do the resuscitation, how the lactates are changing. The trend is more important. And secondly, how long the lactates will stay high. If they stay high for more than 24 hours, then the mortality is low. Elevated for more than 24 hours, 25% mortality, and elevated for more than 48 hours, 86%. So it's a very good marker of our prognostic marker, the lactate levels. Now, these are the different references that I have used for this lecture. The New England Journal of Medicine, the article published in 1994, which is a very interesting article to read. I would definitely ask all of you to go through this European Guidelines, Management of Bleeding Trauma Patients, the European Guideline 2010. It's a very nice article, very well written. And then one review article which has appeared by Mark Midwinter, and Acute Trauma Coagulopathy is another article. So these are the 4 articles. Very much for your patience.